very important topics regarding neurosonogram in newborn, because every preterm baby we have to be screening for IVH and later periventricular leukomalacia and also hydrocephalus. In spite of this, we do encounter hydrocephalus following periventricular hemorrhage, as well as following neonatal sepsis and meningitis. It is there right now. We have 3 to 4 cases in the ward, and even though we finally go to the sonologist to get the final detail, it will be good if we pick it up and then manage accordingly. And so neurosonogram regarding IVH and and intraventricular hemorrhage and also hydrocephalus is a very important aspect of neurosonogram, which I think will be very beneficial to our postgraduates. So this time I think it is Dr. Divakar sir will be taking it today, I think. So yeah, so Divakar sir, good afternoon, very good afternoon, and so extremely sorry for starting this late, sir. Divakar sir.
Dinakar sir.
Dinakar sir. Hello.
1 second, sir. 1 second. Let's see.
Prashantha?
Yes, sir. Dinakar sir, good afternoon.
Prashant?
Yes, sir. Yes, sir. Yes, sir.
No, Tinama. First, no pregnant.
Yes, sir.
Dinakar sir. Hello.
Dinakar sir.
Dinakar sir.
He is there, sir. He is there. He is there.
He is there, no?
Yeah,
sir. Yeah. Hello.
No problem, sir. He's there. He will join us. Maybe some internet issue. He's there. Yeah. Here
okay,
is what.
Okay. Because only yesterday we were listening to his talk in another webinar regarding management of babies with severe respiratory distress.
Yes, sir.
And, his voice is very, very unique. And I think today also we are going to listen to him on IVH, PVL, and hydrocephalus. Over to Dinakar sir.
Yeah, I'll take the class, sir, today.
So you are taking the class, sir?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay, right. Okay.
All right, sir. All right, sir.
Right, sir. Thank you, sir.
Yeah. Thank you. Thank you. Thank you. So again, good afternoon, everyone. We will start the session now. And first of all, I would like to thank sir for giving us an opportunity and NNF Tamil Nadu and all the attendees who have been learning and trying to understand. So as we know that the use mute yeah. Okay. Yes. So ultrasound, use of ultrasound has become a part and compulsion now in the management of newborn because of the advantage of real-time picture what we get and the prediction of certain complications, which has given ultrasound an extra edge along with the clinical skills. So today we'll be discussing and we'll be discussing on intraventricular hemorrhage, their identification, grading, pitfalls, ventriculomegaly gradation, hydrocephalus, basically measurements, PVL and PVHI. So let us start from the basics. As usual, the basics of our medicine is anatomy. So you need to have an idea about how to do it. Can you see my slide? Can you see my slide?
Yes, it's visible.
It's visible. Slides are visible.
Yeah.
Okay. All right. So we will start with basically hemorrhage. When we say it can happen from either venous system or from the arterial system. So either of the thing, or blockage, either it can burst open or because of the block of either the arterial and venous system. So when it comes to venous system, we have sinuses and veins. So our skull has got a special venous system called as sinuses. We have a falx cerebrae separating the two cerebellar hemisphere, two cerebral hemisphere. The superior surface of the falx cerebrae, you have your superior sagittal sinus. Inferior sagittal surface of falx cerebrae, you have inferior sagittal sinus. That will get connected to straight sinus. Then we have a lateral sinus and transverse sinus. And straight sinus all forms a confluence at the back of the head, and then they form your sigmoid sinus, and then it drains down into the heart by internal jugular vein. This is the venous system. When it comes to arterial system, we have got three arteries: anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, which supplies the brain. So anterior part, middle part, and the posterior part. I mean, to have a rough idea about the arterial supply. When it comes to bleeding part, it is the inside of the brain and their branches, where either because of the hemorrhage, there could be a block which can lead to compression of the vein, which will lead to periventricular hemorrhagic infarction, what we call. So today we'll be discussing on all these aspects. So first thing is there are a few things which I have written here. I'll show you this. Yeah, this is the lateral ventricle, which we have taken as a reference. You can see. Can you see my cursor? Cursor, is it visible? My cursor is visible? No.
No, sir.
1 second. Control. Okay. Yeah. So this is your internal cerebral vein, which is important. You can see the location of internal cerebral vein. Can you see the marking now, which I'm doing? Okay. This is your internal cerebral vein. Then you have basal vein of Rosenthal. That is on the superior surface of your inferior horn of lateral ventricle. Can you see this? So this will go join internal cerebral vein, basal vein of Rosenthal, joining the vein of Galen or great cerebral vein, then to your straight sinus, then internal jugular vein. This is the thing. So here you can see a venous angle. So whenever there is a bleed in this is a point where caudothalamic groove. Whenever there is a bleed here, it can compress on this venous angle, because of which the venous drainage system of this particular part will undergo venous distension and venous hemorrhage. We call it as post hemorrhagic venous infarction. So this internal cerebral vein you need to remember, basal vein of Rosenthal you have to remember, and drains into vein of Galen, then into straight sinus, sigmoid sinus, and then it goes into the internal jugular vein. So I hope things are, you can remember all this. Next, I'll play a video which will give you an idea. So you can see here in the video, this is your topmost, corpus callosum, inferior sagittal sinus, that is inferior surface of the falx cerebri. Then you have below that you have white color thing, that is your third ventricle. Above the third ventricle, you can see your internal cerebral vein, which is draining to great cerebral vein or vein of Galen, into your straight sinus. You can see here. Then we are seeing the lateral sinus, where it forms the confluence, and then it drains into sigmoid sinus. Next one you will be seeing now. Yeah. So it's getting rotated now. So you'll get an idea. Yeah, that is your sigmoid sinus, then drains into internal jugular vein. So I hope you got an idea about the venous drainage system of the brain, a brief venous drainage system of the brain. Clear? So you can see this is your the topmost part, your suprasagittal sinus. Then now you'll see the infrasagittal sinus, which is encircling around the corpus callosum. Then you can see your great cerebral vein, and the superior surface of the inferior horn will have basal vein of Rosenthal, which will join the internal cerebral vein into the great cerebral vein. Then you will start seeing your straight sinus, which is straight, and then on posteriorly, all the sinuses from right and left forms a confluence of sinuses. That is your lateral. Then it will drain into the lateral sinus. Then, see, once you understand this venous drainage system, it's easy for you to remember the block and the pathology, and you can easily check. We do even internal cerebral vein Doppler as well. I will tell you, based on that, there's a grading system where you can anticipate and predict the IVH. Sigmoid sinus, you can see. This is your anterior cerebral vein. Internal cerebral vein is different. Anterior cerebral vein is different. So this is your deep middle cerebral vein, anterior cerebral vein, middle cerebral vein, forming the basal vein of Rosenthal. Can you see now? So it's very, very clear now how exactly it is placed. So in internal cerebral vein, we do a Doppler and we do grading. We reduce the speed of the Doppler to less than 15, and then we take a Doppler and we see there should be a continuous waves what we get. That is normal. That is grade 0. There will be interrupted wave, grade 1, grade 2, and grade 3, which will predict if it is there, like a curtain box. If you get the Doppler waves, that will predict the IVH in the baby. So that I will show you. We have a separate slide. So incident, I'm not going to talk too much about the theory. We all know that it's around 15 to 20%, less than 32 weeks, less than 1.5 kg, and kids who are more than 32 weeks, more than 1.5 kg with associated conditions like birth asphyxia, tension pneumothorax, hypotension, all these things. So it will all lead to your bleed. So screening wise, less than 28 weeks, less than 1 kg, less than 28 weeks, less than 1 kg, or less than 1.5 kg on life support. Within 6 hours, you do the first scan by 6 hours. Then you do on day 3 to 1 week. Then you do at 4 weeks and at the time of discharge. Suppose if it is if the baby is 28 to 32 weeks or less than 32 weeks, between weight 1 to 1.5 kg without life support, we do on day 3 to 1 week, then one month, and then at the time of discharge. More than 32 weeks with associated risk factors, with birth asphyxia, acidosis, surfactant, on ventilator. In all these babies, you do within 1 week and frequently as indicated. This is another flow chart to admit the baby. Suppose baby is on ventilator, less than 32 weeks, less than 1 kg, you do first scan within 6 hours, then by 72 hours, then by 7 days, then 14 days, and weekly till discharge. If there is associated abnormal findings which we find, like periventricular play, cyst, germinal matrix, or interventricular hemorrhage, or hemorrhagic infarction if it is there. Why specifically? Because most of the bleeds which happen within 24 hours of birth, by maximum, by almost 90% of the bleed is seen within 3 days of life, and most of them bleed. Whatever, if it is at all, if it is there, might occur before 7 days. That's why day 3 scan and day 7 scan is important if we are suspecting any bleed. How to identify the IVH? We need to go with coronal section. So can anybody tell me where is the germinal matrix present? In any of the volunteers?
Autothalamic group.
Autothalamic group. See, this is the ventricle. So I'm marking it now. Can you see? Like a thin strip.
Lateral ventricle.
Yeah. So it's between below the lateral ventricle and your caudate nucleus. You see this a thin strip line like this. That is your germinal matrix. So which will which is present all over subependymal region of lateral ventricle up to even up to the third ventricle when they are less than 24 to 26 weeks. But eventually all this convolute and finally you see by around 32 to 34 weeks at the caudothalamic tube. That is where germinal matrix. That's why more than 32 weeks of gestation or more than 34 weeks of gestation to be very precise, germinal matrix bleed is very, very uncommon. Not that it is not seen, it is uncommon. So this is a point where they can have, can you please mute this and take this down. So this is how, in order to get the, check for the IVH, what section is this, where we have taken the section? Can anybody tell me which coronal section? The first part we take frontal lobe, next anterior rhon, and the third section we take at the foramen monroe. So this slide is where we have taken the slide. Which section is this? Can anyone tell me?
Body of lateral ventricles.
Sorry?
Lateral ventricles.
Yeah.
Body of lateral ventricles.
Yes. So that is, ideally you can take even at the foramen monroe level, or you can sweep it front and back a little bit. Sagittal section, parasagittal section, in coronal section. Now coming to the sagittal section for IVH, parasagittal section is a place where you take look for bleed. Can you see the slide here? So this is the parasagittal section, and I have marked. So this is your caudate nucleus. See the caudate nucleus, which I am marking now in the ultrasound image, and then here you can see your thalamic, which I am marking in mute. See, you can see echo dense region in this particular part. That is your bleed. Clear? Grading, this is the papillae, which says, grading of which was done in 1978. But I will tell you the thing once with other classification. Imaging of cranial ultrasound, acute hemorrhage is always echogenic. Mute. Second. Done? Okay. All right. So care should be taken not to diagnose acute hemorrhage, not to miss the acute hemorrhage, and not to diagnose if it is only not very highly echogenic. So I'll tell you the pitfalls which can mislead you, thinking that it could be hemorrhage, and then you will be surprised that there is no hemorrhage. So, and one more thing is large hemorrhages which develops in a short span of time, and plus where it can, if it persists for longer time, clot formation, and clot will retract and forming the edge. So you'll have hyperlucent and echo dense and echo lucent, like that changes you will see in the ultrasound image. Now, Volpe's classification makes more sense. Here you see germinal matrix hemorrhage confined to germinal matrix hemorrhage, or if at all, if it bursts open into the lateral ventricle, it is 10% of the ventricular area. Suppose there is germinal matrix hemorrhage with 10 to 50% you cover the ventricular area in parasitical section, or more than 50% of the ventricular area, that is grade 3. And the last part is your periventricular. If there is a huge hemorrhage causing venous infarction at the venous angle, which I showed you, which will lead to post-hemorrhagic hemorrhagic infarction, venous infarction. So that is your separate notation it has been put. Suppose if you take the earlier papillae classification, small hemorrhage confined to germinal matrix without the adjacent parenchyma, there is nothing called small, big, medium hemorrhage there, not there, has gone into the ventricle, not gone into the ventricle. Suppose if it has gone into the ventricle, whether it is 10%, 15%, that makes more logical sense. That's why we go with Volpe's classification. Whereas in papillae classification, it is not clearly defined. So it is not that accurate. And this is based on the CT scan, not on the ultrasound imaging. And it was done in 1978. At that time, it was, at least somebody thought about grading and classification. That's why whenever we do, we remember that thing, but we follow Volpe's classification. So grades of interventricular hemorrhage, gross section I have given you. If it's confined into the germinal matrix alone, or less than 10% of your ventricular interventricular bleed, ventricular area, that is your grade 1. Then grade 2 is 10 to 50%, grade 3 is more than 50%, and your grade 4 grade 3, and grade beyond grade 3, it is acute hemorrhage blocking the venous angle leading to infarction. So now this is the this is the brain tissue where the bleeding has occurred, the fetus brain. First thing is you can see, and this is an extreme premature baby brain, because brain is very, very smooth, like a mushroom, not like a broccoli. So even in ultrasound also you'll find the same thing. So you can see a bleed here. You can see some amount of bleed here as well. This is your grade 1. Grade 2 in pathology, you can see it has bursted open into the ventricular, and you can see that easily it is up to 50% of your ventricular area which is covered. So this is the bleed, what you are seeing. So I'm going a little slow so that you understand. In grade 3, you can see here ventricle is also dilated, plus it is covering more area. Grade 4, you can see the hemorrhagic infarction, because you get your terminal vein here that will lead to block, or internal cerebral vein or a terminal vein, which will lead to hemorrhage. Now coming to the grade 1. So now we got an idea what is grade 1 into the germinal matrix at the caudothalamic notch with no or minimal bleed into the ventricle, that is less than 10%. So this is the image where the schematic diagram where you are seeing at the caudothalamic groove. You can see an echo dense lesion here. Here, this is the echo dense lesion. Both sides there is a bleed. So you can see here. So we take a parasitical section. So normally what happens, there is a dip you see, a groove you see in this region. So the groove is maintained. See, the groove is maintained, this groove is maintained, but here it is with a bleed. That is your grade 1. Next. Now, can anybody tell me there is a bleed or no bleed? Anybody can unmute. First, they have to tell me what section first picture is, what section second picture is, where we have taken the section, and plus you have to tell me on looking at both the section what you would tell for doing an ultrasound scan. Quick. We have so many topics to cover. Can anybody unmute and tell me? Coronal section, very good. Fast.
There is no bleed.
Why do you think there is no?
Similar and
Can you see echo-dense lesion here? Small echo density is there.
yes, sir, yes.
Okay. So you think there is no bleed, but you have to tell me why there is no bleed.
The caudothalamic groove is intact.
Very good. So you have taken in the sagittal section, always any bleed, any abnormal pathology, you have to see two different planes. And if possible, even in the supplementary window as well. So caudothalamic groove is intact. Correct? So
Yes.
in coronal section, you got a feel that there could be a bleed. Then in parasagittal section, when you took, you saw that the caudothalamic groove is intact. Plus, you can see this is your this is the choroid plexus. Can you see here? And even the posterior horn of the lateral ventricle is empty, and it's not no clot is there, nothing is there, and it looks fine. So anterior tip of the choroid plexus, I have told you in normal variant in the last previous class that it can cut out feel you get or bulge feel you get. That's why you need to check at the caudothalamic groove. Extends into the caudothalamic groove, but this is not IVH. Very good. This is the first pitfall. Clear? I'm sure grade 1, you got an idea. Now, can anybody tell me which section and what is the thing? Quick. You have taken a coronal section, you have taken parasagittal section. I have marked it, the abnormality, where exactly it is. Now you have to tell me whether there is a bleed or no bleed. Quick. Bleed, no bleed. Unmute and tell me quickly.
There is a bleed.
Why do you think there is a bleed?
It is extending beyond the caudothalamic groove.
But I feel the groove is maintained. I feel just the bulge of choroid plexus. So this is the another pitfall. But you need to look from the supplementary window in all these situations will always help you. So there is a confusion in this, because when you look at first picture, both coronal and sagittal, you get a feel there is a bleed. But when you take parasagittal section, you can see, but if you look carefully, the groove is maintained. But this is a dilemma where it could be bleed, it could not be a bleed. In that situation, please go with your other windows, supplementary windows, and have a serial monitoring of the scans of the ventricle and the bleed. So yes, it could be bleed. It may not. There may not be any bleed. But in this situation, if you find serial ultrasound images will help you in coming to the conclusion. Now coming to the grade 2 bleed, presence of blood within the lateral ventricle covering up to 10 to 50%. So this coronal image, both I have put here, and you can see there is in one image, first image, there is both the sides there is ventricle, and can you see the bleed? Can you describe the bleed? Where all bleed has gone? So you can see here, right? There is a lateral ventricle. You can see a bleed here. Then through foramen Monro, you see the bleed here. And even third ventricle also you are seeing the bleed. So if it covers blood in lateral and third ventricle seen, but you don't see any dilatation of ventricle, so interventricular bleed tends to, in this situation, posterior horn is little on the lower side. If you actually see the shape of the lateral ventricle, so it usually slides and gravitates and settles down in your occipital horn. So that's why when you see through posterior fontanelle window, you can see a clot. Sometimes if you're checking it late, in the parasagittal section, you might get a groove being normal. But if you are seeing a clot in the occipital arm, that is definitely a bleed. Clear? So this is another picture where which I was talking about. In the occipital arm, the clot has got settled here, gravitated and settled here. So there is a bleed, and it has gone down here. Here also you can see. So these are all important, especially when you have confusion. So in grade 2 sagittal view, you can see there is the groove is altered. Can you see the groove which is being altered? Plus you see one layer of echodense, then hypoecholucence, then again echodense. Like, you know, tram track, you get a feel. So this is a bleed, and plus in the second image you can see it has gravitated already into the occipital horn. Plus you can see the obliteration of caudothalamic groove. So this is definitely a bleed. Now you have to tell me there is a bleed or no bleed. Unmute and tell me. I have marked specifically. What do you feel? Bleed is there, bleed is not there, or would you like to go with another window? Quick. Unmute and tell me quickly. Fast.
Bleed is present, sir.
Bleed is present. Why do you think there is a bleed?
There are more echodense in dependent part of occipital horn.
See, I told you there is, the thing is, the caudothalamic groove is obliterated. Plus, if clot sits and sometimes take the shape of the choroid plexus or the shape of the ventricle. So in that situation, you can see this echodense and echolucence. So if the surface of the choroid is smooth, you see this clot retracted. So there is echodense, echolucence, and then again you see a smooth margin of the choroid plexus. Suppose if it is rough, it is very difficult for you to diagnose in such type of lesions. So that is what I am trying to tell in this pitfall in grade 2. Suppose if the bleed is big, because obviously grade 2 bleed will be 10 to 50% of the ventricular system without dilatation. So you have bleed in the caudothalamic groove, you get confused, but the clot is well formed and taking the shape of the ventricle, and choroid plexus being smooth, you see layer by layer. First you see echodense, echolucence, and echodense of the surface of the choroid plexus. Suppose if it is rough, this signature will get altered. So in this situation, if caudothalamic groove, if it is not very obvious, you might find it difficult if you are doing it later scans when they come for follow-up. So now quickly we'll go with the next, this one. So picture A, bleed there, not there, yes or no? Quickly, at one person should unmute and tell me. Bleed there, not there. Picture A. Who's going to unmute? Go ahead. Picture A, bleed, no bleed.
No bleed.
Oh, bleed is there.
Bleed is there.
Two answer. One is no bleed, another I heard it as bleed is there. So I have already told you, in occipital or if there is a clot, close your eyes and say there is a bleed. Plus, you can see caudothalamic groove, there is a bulge. See, ideally what happens, it will be like this groove. But if bleed is there, this caudothalamic groove will get filled up with the blood. So first one, there is a bleed. Now tell me second one. Bleed there, no bleed. They have marked something here. What is it?
Bleed, sir, present.
Yeah, because if clot is there in the occipital horn, bleed is there. Now, third one. This is tricky. This is what I was telling about the pitfall. So tell me, bleed there, not there in picture C.
No bleed is choroid plexus.
Why do you think there is no bleed? Why do you think there is no bleed?
Dependent areas are free.
Correct. Then groove, there is no bulge here. The groove is still there. Correct?
Yes.
Correct. So now, which I was telling about, clot should be able to be seen in more than one plane. whenever you do an ultrasound, if you see a clot in parasagittal section in the occipital arm, try to see from the posterior supplementary window and confirm it. Sometimes if you increase the gain or if your angle of the probe is not appropriate, which can give an artifact of bleed. So that's why you should always confirm in two planes. So now picture 1, bleed there, no bleed. See, if you look at this picture, you see there is something here, correct? Next, we took one more. This is because your occipital horn is facing upwards. This we are seeing through which window?
Posterior.
Erected. Yes, posterior frontal, correct. So you don't see anything here. So always confirm with two planes. So this is what I was talking about. So especially when you are looking at bleed, so no clot in the posterior fontanel view. So that's why there is no bleed. Grade 3, presence of blood within the lateral ventricle with dilatation more than 50% it covers. So it is like quite obvious. Unless we are blind, we don't miss this. But here also there are few pitfalls which you need to remember. So in coronal view and in sagittal view, there is no doubt there is a clot, big clot is there. Your thalamo-occipital distance is increased. Ventricles are dilated. Your lateral ventricular height VH is increased. Then you have your anterior wall width which has gone up, and you take your ventricular index. So there is dilatation, no doubt in that. So this is grade 3. So in sagittal view and clot taking the shape of the ventricle if the bleed is huge, which I was talking about. So this is how exactly check the shape of the ventricle. So you can see here, which I have marked it in the arrow, how it has taken the shape of the, plus there is dilatation of the ventricle. So you have to refer to the chart. We have a chart, so which will give us what is the range for the dilatation for each ventricle. So next, now can anyone tell me there is a bleed or no bleed in first picture? This dilatation is there. So whether it is with because of it is IVH or no IVH, it is grade
IVH
3.
is present.
First slide. Don't look at the second one. First one, which I have marked it. IVH is there. Why do you think IVH is there? I will say that it is not IVH, it is infection. Yes, there is dilatation of ventricles. I agree. Correct. There is dilatation of ventricle. Correct. It is there. No. Yeah. There is dilatation of ventricle. I agree. But I'm not seeing any clot. But one more thing is you can see the layer which is thick, ecolucent, the inner lining of your ventricle. So that typically you see in meningitis or infections where you see. But if you see only dilatation without the signs of bleed, then you cannot call it as IVH. That point you have to remember. That's why I put this slide. See, in the second slide, there is obvious clot with loss of caudothalamic groove plus dilatation. So this is bleed. Pitfalls which I was talking about, grade 3 IVH with postventricular extension with dilatation of ventricle, and here also you are seeing one bleed plus dilatation you are seeing. So this is definitely, suppose if there is no clot, if it is just the dilatation of ventricle, then you cannot call it as IVH. Now, presence of periventricular hemorrhagic infarction. So imagine there is so the first image, you can see a lateral ventricle here. You can see a bleed here on the left side. On the right side, if you see, there is echodense lesion present. You don't see lateral ventricle here, it is already filled. So parasagittal section you take, again you see the finding here. So basically whenever there is, so okay, now I will ask one question. According to you, which one is more dangerous? A large grade 1 bleed or grade 3 bleed? Which you will be careful when you are counseling the patient. Can anyone tell me? Big grade 1 bleed, how will you counsel? The saying that, or which you are worried about or not, or grade 3, which you are worried about. Which one is more dangerous? Can anybody tell me? Which one is more dangerous? Quick. You have to respond because this class is going on for a very long time now. You have to tell me grade 1 is more dangerous, large bleed, or grade 3, which is more, which you'll be more worried about?
Grade 1 is more. Good afternoon.
Good afternoon. Grade 1?
Grade 1 is more dangerous, more difficult to counsel.
Why do you think grade 1 is more dangerous compared to grade 3?
Grade 1 can, if it's extending, it can result in grade 4 IVH, periventricular hemorrhagic infarction, by compressing the terminal veins.
Exactly.
Oh, yes.
Yeah. So now that's why it is important that whenever there is a grade 1 bleed, you need to have a serial ultrasound monitoring to see whether the bleed is extending or not. If it is extending, it can lead to blockage of terminal vein or the venous angle and causing the post-hemorrhagic venous infarction. So you have to be very, very careful. So you will see that I saw there was grade 1 bleed. There was no, the bleed has not gone into the ventricular system. There was no dilatation. And then you counsel that, patients, counsel the parents that it's fine, grade 1 bleed, nothing to worry. And then suddenly after 6 hours, you see a baby becoming, deteriorating. Then again, parents will ask you, 6 hours back, you said that it was fine. Now you are telling me that the baby has become really bad. So be very, very careful. This slide is the latest, these are the use of role of Doppler, which I have put in, where you can predict the intraventricular bleed. So in this slide, what they have done is, this is a study which was done, where they have tried to calculate the peak systolic velocity and diastolic velocity, and they have calculated the resistive index, mean velocity, and your pulsatility index. So resistive index is your peak systolic velocity minus diastolic velocity by your peak systolic velocity, whereas your pulsatility index is peak systolic velocity minus end diastolic velocity by your mean velocity. That is your pulsatility index. So what they have done is they have done a Doppler study on the 2 groups. They named it as a hemorrhagic group and non-hemorrhagic group. But what they have noted is those babies who had, they have compared and they have done follow-up in all these extreme premature babies. So they have checked what is the peak systolic velocity in kids who had this particular velocity and what is the outcome, whether they had bleed or not. And they've compared with end diastolic velocity, how much end diastolic velocity in them, whether the bleed has happened or not. And they've also compared on the resistive index and your pulsatility index. So among this, they have found out that end diastolic velocity with more than 9.2 centimeter per second are at increased risk of developing intraventricular hemorrhage. So when you are doing a Doppler, if you get an end diastolic velocity of more than 9.2, then you should be careful that this baby can develop intraventricular hemorrhage. So you should be very, very, if you're ventilating, you should be very careful when you're handling the baby and when you are managing the baby. So this is one of the studies where end diastolic velocity gave them a prediction for bleed is happening or not happening. So they followed up with those with more than 9.2. They found out that baby had bleeding and you can see resistive index also has gone up. 0.6 to 0.8 is your normal level, but it has gone up. Initially it was normal, but later with end diastolic velocity being more than 9.2, they have observed that this group has developed bleeding. Non-hemorrhagic group, those initially with their end diastolic velocity of less than 9.2, like 5, they didn't develop any bleed. So this is one of the predictor or marker which was done, study was done. So if you have a doubt, you have checked in 2 planes, you are confused, or then you can go with color Doppler and see at the level of Monroe. So preferably go with a high frequency because you are trying to look at the vessels radiating the ventricles, and you can see before germinal matrix hemorrhage the color Doppler, and after germinal matrix hemorrhage we can see there is disappearance of the color when bleed happens. So this is another way. If you are getting confused with whether bleed there not there, you can go with color Doppler also and you can see. This is what is this vein? This is your internal cerebral vein, correct? So you get your basal vein of Rosenthal here, then internal cerebral vein which goes, and then great vein of Galen or great cerebral vein, and then to your straight sinus, then to your sigmoid sinus. So here what we do is we decrease the Doppler speed to less than 15, keep it as 12, less than 15, and then take a Doppler. So when you take a Doppler, if you get a continuous waveform, you should get like this in picture A, which I'm showing now. So if that is there, there is a steady flow. So perfusion with constant perfusion speed. So it is fine. Suppose if it starts fluctuating, see, the waveform starts fluctuating, and the fluctuation is less than the half of the maximum speed. Plus now in grade 3, in grade 2, you see waveform fluctuating more and forming like this waves. And picture D, which I'm showing now, you are seeing intermittent, pulsatile-like, and waveforms are totally not continuous. It is totally interrupted. So especially this and this can also predict your bleeding, IVH. So when you do a Doppler of your internal cerebral vein, if you don't get a continuous steady waveform, and it is like our Nityananda telling E is equal to MC square, like that. So if you get a continuous flow form, it is fine. If you go into grade 2 and grade 3, that can also predict your bleeding. So this is what I have written, compiled a slide, the summary of the slide with coronal view and sagittal view of grade 1, grade 2 and grade 3. So we will quickly revise, which is confined to the caudothalamic groove with less than 10% involvement of the ventricle is your grade 1. If it is 10 to 50% without dilatation, grade 2. Grade 3, you get dilatation plus more than 50% of involvement of the ventricular system. I'm sure I'm able to fix in a mind what are the grades, what are the pitfalls, and how do you predict or anticipate the bleeding outcome. That is again theory, you can read, which all will lead to periventricular hemorrhagic infarction, hydrocephalus, all those things. Now coming to the choroid plexus bleed. So when we talk about bleed, one is the intraventricular bleed, where you have your germinal matrix bleed, then you have your choroid plexus bleed, then you have your cerebellar bleed, then you have your interparenchymal bleed. So we finished interventricular bleed, now moving on to the choroid plexus bleed, which is not that common compared to the germinal matrix bleed. It is usually anterior to posterior, it can range. I've marked it in the yellow arrow, and more than the 12 mm in length, the diameter, hyperechogenic or echodense, and if it is nodular, that could be That's how the choroid plexus bleed develop. I'm not going into too much this thing. Can anybody tell me what I have put, which picture I have put? Please unmute and tell me what is the section which we have taken and what structure are we looking at and what I have marked in the red arrow. Quick. Please unmute and tell me what is this. See, we finished germinal matrix bleed, choroid plexus bleed. What is it? Okay, what you are trying, what I have marked, which structure I have marked?
Basal ganglia.
Huh?
Second
Master
picture is the
vein.
fourth ventricle with cerebellum.
Huh?
Second picture is fourth ventricle with cerebellum.
Okay, what I'm marking now? What
This fourth ventricular bleed or a cerebellar bleed.
Cerebellar view. So I'm marking this as cerebellar bleed. Okay. So cerebellar bleed, this is how it looks like. So now you tell me what I'm showing in the arrow and what I'm trying to tell. Where is the bleed? Do you? Okay. Quick.
Temporal lobe bleed.
Temporal lobe. There is a bleed. Correct. This is your intercerebral bleed, which has caused your midline shift. You see, midline is shifted. Ideally, it should come here. It is shifted. Plus, you can see a generalized, edema. So all, everywhere you see all little, light up things. So this is your interparenchymal bleed. This is how it looks like. Now we'll move on to the periventricular hemorrhagic infarction, which already I gave you the heads up introduction, how exactly it happens. 15 to 20% with IVH bleed being larger, causing the block. 50% lesion can be extending into the frontoparietal region. 50% might be localized. So basically, whichever side there is a huge bleed and block, that particular side you have changes, correct? So it is unilateral most of the time. So and you will have a single large compression and single large area of hemorrhagic infarction. So it is unilateral, localized, and even if there is a cyst formation post infarction, it is unilateral cyst or a single cyst, what you will find. Now, which I was talking about, this is your venous angle. This is your internal cerebral vein. We call this as a terminal vein or the venous angle, but thalamostriate vein. So internal cerebral vein, I have showed you. This is your internal cerebral vein. This is your terminal vein, which you are talking about, where your caudothalamic groove is present. You can see the third ventricle here. Thalamus will sit in. So thalamus will sit here like this, correct? And then here you get your caudate nucleus. So this is a place. Whenever there is a bleed, this can block your terminal vein. So based on which all veins are blocked, you get infarction accordingly. Now I'll play a video. You can see the blood flowing, and you can see, I'm sure you can see that small blood which is flowing through the terminal vein. Now bleeding has happened. So bleeding is pressing on the terminal vein, and then you are seeing on the left, you can see now, this is how it works. See, now again I'll play the video. You can see how the post hemorrhagic venous infarction happens. You can see on the image, the video, the bleed is increasing, acute bleed, leading to constriction of the terminal vein and then causing hemorrhagic infarction. So this is how it causes hemorrhagic infarction. You can see here. So this is the bleed, and you see that will lead to again hemorrhagic infarction and hemorrhagic bleed. Clear? So this is how the pathophysiology, which I've already told you how it happens. So now bleed starts as a large distending the germinal matrix, then obstructing the terminal vein, then blockage of the terminal vein leading to the flare-shaped hemorrhagic infarction. This is how it looks. Your hemorrhagic venous infarct. There is a bleed. Then you can see here your distended terminal vein in this section, and then you can see complete venous hemorrhagic infarction. So now you have to differentiate from the post venous hemorrhagic infarction versus periventricular leukomalacia. So we know that venous infarction is from venous. This is ventricular leukomalacia from arterial. On whichever side there is an acute large bleed that is unilateral, fan shaped. Here it could be mainly bilateral, patchy, irregular. The ipsilateral large IVH, that is small, no IVH. Rapid progresses because you have seen, and then within 6 hours you see it is getting blocked, and then it is very, very rapidly progressing, whereas PVL is slow progress. Single cyst as a complication, there it could be multiple cyst. Venous infarction, cavity can communicate with ventricle from frontoparietal region. Here it is more hyperdense echo texture, which takes a longer time to disappear. So post hemorrhagic venous infarction, you can see here, this is the slide which I have put at the ultrasound section. You can see how it looks. There is a bleed extending into the third ventricle, both lateral ventricle, and then causing, on the left side you see a big bleed causing the infarction. On parasagittal section also you can see. And here color Doppler is put. You can see the color is not there in this particular area. All right. Now this is our acute appearance. There was, you are seeing some flare here. That's all. Then in the sagittal section also. Then later you see a cyst formation in both the places. So you need to, whenever there is an acute large bleed, please be very careful. So this we have put color Doppler, and we are trying to see the terminal vein. So here you can see a thick terminal vein in the color Doppler. Here you can see it's getting blocked. So that's why in next image you see terminal vein is fine here, but here you don't see because it is completely blocked. So color Doppler also will help you very clearly to identify. This is a different location picture, how it looks, which I have put. Summary, optimal timing, less than 32 weeks, less than 1 kg, 6 hours, then by 72 hours, then within a week, and then weekly till if the pathology, depending on the pathology, or at the time of discharge. More than 32 weeks with associated rough NICU course, please do it 6 hours, 72 hours, and 1 week, and weekly follow. If there is no risk, then by 72 hours or by 1 week, and then at the time of discharge should be sufficient. 3 scans should be sufficient, but based on the pathology. Now coming to the ventricular measurements. So there is Levin index or Levin ventricular index, Davis scoring. Then you have other specific ventricular measurements. So basically here you are measuring ventricular index is you are measuring from distance from your falx cerebri. This is your intrahemispheric fissure. From here to the maximum lateral most part of the anterior horn of the lateral ventricle at the level of foramen Monro, third ventricular level, you are measuring. So this is your ventricular index, and then you are charting it. If it is 4 mm above the 97th centile, which I'll show you the chart, then there is risk of 50 to 60% being shunt dependent. Suppose if ventricular index is more than 4 mm, that is used as a criteria for interventional criteria. Suppose if anything above 97 centile, it may be associated with 16% need of VP shunt. So, but mostly we use Davis scoring only. This is the chart with your 3rd centile, 50th centile, and 97th centile. And this is the chart which is showing 97 centile plus a dotted line suggesting the 4 mm above the 97 centile. So if you are plotting it here, then intervention criteria, if it is that is around 50 to 60% might require shunt here. Suppose if it is here, it might be around 16% shunt. We'll get a prediction of the thing. Davis scoring will take into consideration your anterior horn width. We measure diagonally. Then you take 3rd ventricular width, we take thalamo-occipital width, the combination of 3 measurements, anterior horn width of 4 mm, more than 4 mm width, or more than 1 mm of 97 centile, the third last line, TOD, thalamo-occipital diameter of more than 26, or more than 1 mm of your 97 centile, and 3rd ventricular width of more than 3 mm, and more than 1 mm above the 97 centile. So if you are taking 97 centile, more than 1 millimeter above 97 centile, or if you are taking individual specific measurement, anterior arm width of 4 mm, thalamo-occipit of 2.6 mm to 26 mm, and 3rd ventricular width of more than 3 mm. These are the 3 scores which we take for the prediction of your, for the measurement and telling that, when there is ventricular dilatation. Anterior horn width, you take the diagonally, you take this maximum width diagonally, not the axially. And then this is your ventricular height. If you take this ventricular axis, but you just remember in anterior horn width, that is important, 3rd ventricular, and your thalamo-occipital distance. These 3 things is good enough for you. And there is 2 charts. One is within 4 days, there is 1 chart. And for after 4 days follow-up, there is 1 chart. So this is your 3rd centile, 50th centile, and 97th centile. So 3 charts. You have to mark it. Thalamo-occipital distance you take from the posterior aspect of the thalamus to the lateralmost part of your occipital orb, the inner surface of the lateralmost part of your occipital orb. I'll show you how it is taken. So this measurement is also important. As I said, Davis scoring is one which we follow. So from this point, this is your thalamus. From this point, you are taking it till the lateralmost part of your occipital orb. This is your thalamo-occipital distance. Not from choroid plexus, from thalamus. So you take from here. So, and we have a chart within 4 days and more than 4 days, and then you have to mark it. As I said, 1 mm above the 97 centile, or specifically if you take more than 26 mm, that is abnormal. 3rd ventricular width, the best you can take from your, even from your mastoid window, or from temporal window as well, and measure the 3rd ventricle. 4th ventricular measurement also same thing, in supplementary window mastoid you can take. This is hydrocephalus ex vacuo, that is where from outside the bleed is causing dilatation and blockage of cerebrospinal fluid. See, ventricular system is like a swimming pool. Suppose if somebody from outside, if they are pushing, it's like a closed loop. So which also from outside bleed also can cause obstruction and dilatation, or from inside if there is certain capacity of the ventricular system to hold on. If it increases, the volume of that fluid increases within the ventricular system, that also leads to dilatation like a balloon. So balloon can be blocked from outside or from the inside. It's like a closed loop, like a swimming pool. So that's why ventricular hydrocephalus ex vacuo from outside, where you see the convexity, concavity is maintained. Here, see, it is more convex. So these are the 2 types. And measurements, I've already told you how to measure. This is subcortical spaces where you have your interhemispheric length and width, which I've already put in the previous class. I think that you can go ahead with the next one. At least remember this is important. Anterior horn width is important. Thalamus-occipital distance is important. Third ventricle is important. Fourth ventricular width is also important. Apart from that, sinocortical length, interhemispheric fissure, third ventricular width, all these things I have given. You can put it in your while doing a scan or along with your machine, and then you can do it. Assessment of intracranial dynamics of transcranial Doppler sonography in babies. So this is the Doppler what we take, where we take and check for the resistive index and the flow, and we measure the end systolic, diastolic peak. It should be normal, RI should be less than 0.60. Now I'll show you one important thing here. Doppler parameters for anterocerebral artery of a premature newborn with hydrocephalus before and after the drainage. So now I have shown you how to take the anterocerebral artery Doppler, where you take mid-sagittal section and then you put a Doppler at the geno of your corpus callosum in front of that, and then you take a Doppler. So once you put a Doppler, you get your peak systolic velocity and then your end diastolic velocity. So resistive index I've already told you, peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. Ideally the range should be 0.06 to 0.80. So now there is a bleed, and then you are sure about the bleed. Now pediatric surgeon comes, and then you do a Doppler. So this is the compression test which I am talking now. So in the first picture, you take a Doppler, and then you see the measurement. You can see here this resistive index is 0.921. So you take your peak systolic velocity, end diastolic velocity, and then you calculate. Now what you do is, it is like borderline. So they will tell that the resistive index is not that much, we'll wait. So you can tell the pediatric surgeon, hold on. What you do is, you place it here, and then you give a compression here from the probe, and then you repeat the Doppler. That is the second image which I am talking now. Then once you press it, you are mimicking the bleed which could get compress the anterocerebral artery, and which can lead to your hydrocephalus you can expect in them. So you take a Doppler. So you see a peak systolic velocity and diastole is missing here. So it has become negative. And you can see the resistive index after compression, it has gone up to 1.238. It has gone up. So when you did initially Doppler, it showed 0.9. But when you did compression test, you saw diastole reversing and resistive index going up. So these are the babies which would require shunt. So you can tell the pediatric surgeon that please hold on, and you can go ahead and do the shunt. Suppose if it's still, even after compression, if it is normal value, those babies may not require the shunt. So in another third picture, what we have done is, we have done, we have checked, we did the drainage, and then we have checked. So you can see again the diastole and your resistive index has come back to normal. This is after drainage. In the fourth one, again, we have gone with the compression. Still, after drainage, you can see that still the resistive index has remained same. So, basal Doppler, first image which I showed you, that is without any drainage, just regular Doppler. Then you went for compression test before drainage. Then you saw that resistive index which went up. And then you did the basal Doppler after the drainage, and then you went for compression and did after the drainage procedure. So this is also one of the predictor for requirement of shunt or not. Now moving on to the third topic and the final topic, periventricular leukomalacia. Periventricular leukomalacia, I remember it as equidens lesion around the periventricular region which persists beyond 7 days. That is your grade 1. Suppose if this periventricular equidensity having small localized from frontal to parietal, grade 2, parietal extending entire length of the ventricular thing, that is your grade 3, grade 4 from subcortical till the ventricular surface. If it spans, that is your grade 4. This is how I remember. So this is your grade 1, just the periventricular flare persisting beyond 7 days. You can see here. So it's an arterial infarction, what you see. As I said, it is usually bilateral compared to post-hemorrhagic infarction. Next, grade 2, you start seeing frontoparietal cyst. You can see here. Grade 3, ranging from entire length of the periventricular region. Now I'll show you grade 4, which is spanning from subcortical till the periventricular region. Again, so that is your grade 4. Key messages: flare, localized cystic lesion, extensive cystic lesion, subcortical leukomalacia, other things. Thank you. Discard. I hope there was no interruption. My voice was clear and slides were also very clear. Yeah.
Yes, sir.
Dinakar sir. Yes, sir. Kamal sir. Yes, sir.
Yeah, it was excellent, sir. This today's lecture was superb without any interruption, and the pictures were also very crystal clear. And it was, I mean, all those data like delta P and your resistive index were all very well explained. So, and actually, you don't need a hands-on thing. All those ultrasound pictures you showed us were very excellent. And, so, I mean, many things you clarified. So, you told us the basic pathophysiology of grade 4 IVH, which is not actually grade 4. It is a hemorrhage which occurs following block in the terminal vein. So, I think that is an extremely well explained, because this concept most of us don't know. In fact, we came to know about it only during our final year of DM. So, it's very difficult to understand this. So that you have brought it out very well, sir. And, so I'd like to see if the audiences, the participants have got any questions with them, so that we can clarify.
Or if they want to see any specific, if they want me to explain, they can explain. Dinakar sir, are you there?
Hello?
Yeah, please tell me.
Hello?
Yeah. If audience have any question, they can ask. Then we can go for hands-on also. How to measure, because I already shown the picture as sir said, how to take thalamo-occipital distance, how to do anterior on width, ventricular index. So, and the chart you need to plot on what is Levin ventricular index, what is Davis scoring. Yeah, if your audience have any questions.
Sometimes we cannot see the third ventricle clearly. So what would be the other anatomical marking that we can use while measuring the ventricular indices?
See, most of the time what we do is, when you're putting it, please, when baby is sleeping, which even, see, when you're holding a probe itself and when you're taking an image, we'll come to know whether you have done enough scans or not. So when you place the baby, like this, your head base of the skull is like this in certain angle. So you have to adjust either when you're taking your coronal view, or if you're taking an axial view, you have to adjust based on the base of the skull. When baby is sleeping like this, see, our skull is little slanted, the base of the skull. So if it is baby is like this, baby is sleeping with this, you have to see how exactly the position of the head, and you have to imagine the base of the skull, and based on that you adjust. You will definitely get it. See, most of the time what we do is we keep it like this. So we are supposed to keep like this, but we'll keep it like this, thinking that baby is sleeping. So you may not get even the circle of Willis. When you go in mastoid view also, third ventricle or fourth ventricle, you find it difficult. Only thing is you have to imagine the base of the skull and accordingly you have to place the probe and you have to keep swiping and tilting to get a clear image. So first of all, you have to adjust the gain properly. Then you have to stabilize the image, get the image, try to get the image in the center where both parts, suppose if you are taking coronal section, the intrahemispheric fissure should be in the center and both the sides should be equally visible. And if you want to increase the width of your, sometimes you will be going with a very narrow width of your probe. So try to increase the width so that you'll be able to cover maximum structure. And the probes which you use, suppose if you're using different probes, the quality of image also varies. So what if you're trying to look at nearer objects, try to go with the high frequency probes, and especially for the mastoid, if you're go with a linear probe, you will be able to visualize it better. But these are all which will help you. But if you're experienced hand, any probe you give, you will try to adjust and you try to get a better image. Brain is not that difficult to get image. You just need some experience and training. But these are the few tips which which has helped me, which I have told you. Yeah.
Thank you, sir.
Any other questions?
Sir, can you explain the grade 1 intraventricular hemorrhage pathophysiology once again, sir?
Okay. Grade 1. One second. Yeah, see, grade 1, there is a germinal matrix bleed. Germinal matrix is your subependymal region. That means below your lateral ventricle, you get a lining. One second, I'll start showing. Yeah, grade 1 bleed, see, which I was talking about. Sorry, not enough pen. Yeah, see, this is the area where your germinal matrix is seen. It's between your caudate nucleus, caudothalamic groove, and your lateral ventricle. So that is a place where you see, that is called subependymal region, where you might, and germinal matrix vessels is nothing but a pluripotent, it's like a stem cell, which will give the different type of cells to the brain. So this is maximum up to 24 to 26 weeks and can go up to 28 weeks. By around 32 to 34 weeks, usually it disappears, and maximum focus after 28 weeks you see in the caudothalamic groove. So this germinal matrix doesn't have a wall, so it is very, very fragile. So when we talk about the arteries or veins, they come with wall. There are few venous system, few arterial system which is without wall. So germinal matrix is one of it. So whenever there is a rough NICU course or resuscitation requiring for longer time, premature baby, so this can bleed. So this bleed might just confine to the caudothalamic groove or germinal matrix area, or we might notice that it might break into the ventricles, but only up to 10% of ventricle it is covering. Percentage wise, if you tell, it is easy to grade. Otherwise, if I just say that confined to germinal matrix alone, the caudothalamic groove alone, what if there is some amount of bleed? So will you call it grade 1 or grade 2? So that's why your old pace have changed from papillae that up to 10% with caudothalamic groove bleed confined, we call it as grade 1 bleed. Coming to the pathophysiology, as I said, that is a point where, first point where the entire germinal matrix involutes and remains in that particular spot. That's why we try to look at that particular spot when we are checking for the bleed. Yeah, I hope I have answered you.
Yes, sir. clear, sir, now.
Yeah. Any other Any other questions audience has? There are two things. If there are no question, that means either you have understood or you have not understood.
With respect to Dopplers, considering the most common is hemorrhagic infarct. So what's the role of arterial Dopplers in a normal preterm baby?
Yeah, see, especially you do your arterial Doppler to check for your resistive index. That means wherever there is, you expect a very high flow because of pathology. You do, especially in PDA, you do to check for the reversal of flow or resistive index. Then you check for bleed, you check for predicting of bleed. Then that's what I've shown few diagrams. Coming to the venous Doppler, again, internal cerebral vein, which I showed you, where you can predict based on the end diastolic velocity. So there are a lot of studies. This especially the role of Doppler in neonatal brain is the most researched topic. Probably, a lot of studies are still happening where the role is just defined, like how Dr. Daniel Lincoln changed the concept of the use of ultrasound lung, like how we came up with A lines, B lines, Z lines, and lung sliding, lung point. Similar way, there are a lot of work which is being happening in neonatal brain, which was especially with power Doppler. They're trying with power Doppler. They're trying with color Doppler. Most of the articles I was unable to access, but I can see the headings over there. The role of Doppler in neonatal brain is increasing, and our understanding is increasing. It is just that a lot of trials results are yet to come. With whatever it has come, we can predict. See, you cannot predict the outcome of brain injury. That is very tough because it takes time. Brain is a growing structure, but definitely you can predict, as I said, stent is required or not, shunt is required or not, whether there is IVH which is happening or not. So these are the rules. And then with color Doppler, we'll get an anticipation about if color is disappearing, or if it is decreasing, or if the color in the terminal vein is constricting. You'll get an idea that this baby might go into the venous infarction or arterial infarction. So in that way, one is counseling will be easier, and second thing is the sound, the handling, the aggressive ventilation, the aggressive suctioning, all these things can be minimalized. And we will try, see, now we have reached a stage where not just identifying the structure, not just identifying the bleed, anticipating the bleed, and trying to intervene and trying to prevent, trying to think whether we can prevent any complication occurring or not by anticipating and predicting. So in that perspective, role of Doppler in the brain is going to have a huge role. As I said, this is just the beginning. You can take up as a thesis topic as well for this particular thing. The role of Doppler in assessing or in anticipating or predicting. Already few studies which I've shown you. Like that, many other things also can be taken. Especially the color Doppler and the power Doppler, if your machine has, where you can assess the outcome or predict the outcome. So definitely color Doppler of anterocerebral artery, middle cerebral artery, and terminal vein, calculating their resistive index, doing their Doppler, color Doppler, you'll get an idea. See, any Doppler, you check for the systole, you check for the diastole, and then you see whether there is negative tracing or positive tracing. If there is a negative tracing, you try to look for the reversal of flow in your PDA. If you are in your, especially with hypoxic ischemic encephalopathy, also color Doppler will give you an idea. If you are getting confused with bleed, no bleed, clot, no clot, or if there is a cyst which you are seeing in vein of Galen malformation or aneurysms or cyst if it is there. So if you put a color Doppler, you'll get an idea. Similar way, as I said, even intercerebral vein, which I have put, about the end diastolic velocity, which I was talking about. All these things, it has opened up a new perspective for us as well. But the number of studies which was done earlier was very, very limited. Only the role of ultrasound, role of point of care ultrasound, identifying the structure, identifying the pathology, identifying certain problem, but anticipating, predicting, scoring, that is
Hello? Hello? Hello, sir?
Yeah, yes, sir.
Sir,
Another laptop got.
Is there a picture of vein of Galen aneurysm, sir? Do you have any picture? Because we had a child. You had shown a vein of Galen very clearly, which is normal vein of Galen. But how will an aneurysm of vein of Galen look? Because we are supposed to look for it when you have a baby with unexplained CCF and things, hypotension. Is it?
Yes, sir. Yes, sir. I have to, because it is there in my pen drive.
Okay.
So,
Next time, I think probably we can.
I'm right now, sir.
Okay.
But I'll show you next class. Definitely, I'll show you. I can show you arachnoid cyst. I can show you infection, meningitis, slides, vein of Galen malformation. You can whatever. Most of the things I do have, sir. I can show, sir. I can show. Next class, I'll show you.
Sure, sir.
Next class, I'll be taking on ETT lines. How to confirm ETT position, fixing of ETT, then how to confirm the PIC lines, your long lines, all these things I'll be taking, sir. I have few good videos also, especially for ET tube confirmation, and that I'll take in the coming Friday. I'll take that class. Then probably next week we will plan for series of ultrasound lung.
Excellent. And so I think this is something new which we got from this class, sir. That is, we were actually planning to have this class mainly to diagnose bleeds. But now you have given us a class where you can even predict bleeds with Doppler, which we didn't think of.
Yes, sir. Yes, sir. Yes, sir. No, it is just that we are also, I'm also learning, sir. This test on ultrasound was invoked by Dinakar sir only, and then we had series of training session. So
good.
Just one last question. That is it enough only to check for anterior cerebral artery Dopplers, or do we need to check the other vessels?
I have anterior cerebral artery, middle cerebral artery. Go with a temporal window. Get a middle cerebral artery. Put a color. Middle cerebral artery. Go straight and check middle cerebral artery also. And plus, if possible, your internal cerebral vein, if you get it, if you are able to do a Doppler also. But for that, you have to decrease the speed. See, your Doppler concept is like, depending, it will estimate the speed of the blood vessels which is moving. How do we do it? Those which are very, very high speed, you won't be able to get the reflection of those red blood cells if you keep lower speed of the Doppler. So that's why we go with power Doppler or high speed Doppler. Especially if there is a low flow areas are there like brain, try to reduce the Doppler speed to 15 centimeter per second and then try to do it in the internal cerebral vein also. Because that's what I was telling you, the lot of, not just the anterior cerebral artery Doppler, middle cerebral artery Doppler, try to do with veins also. So you'll get an idea about, whatever studies. Yeah, my laptop is getting cut. Yeah, so we have to do, especially when we are reporting for the first time, try to follow like how you report the X-ray. One is cortical area, subcortical area. Then you look at the external surface. Go from dura, your meningeal covering, layers of skin, meningeal covering. Try to look at the distance of subarachnoid space also, width also. I have shown you normal variant, interhemispheric width. But try to focus first on the what you need to focus. That is, if there is a premature baby, sudden deterioration, there is a bleed, you please confirm that. After that, when you're reporting, take those pictures and try to see one by one, 100 to 200 like that. We get some idea. As we are told in previous class, at least 500 plus or up to 1000, then things will be much better. We are now, I myself, I am, because since I work in a private hospital, whatever cases we get, we have, I'm just trying to do everything in this way, but which has opened up for me to even to come up with a lot of studies as well. So try to report it in a very systematic way. Then once you have seen the external structure, then cortex, then deep cortex, ventricular system, then you go with Doppler, anterior cerebral artery, middle cerebral artery. Then you go with your circle of Willis, try to see other structures also, like, even you can see olfactory lobe, hypothalamus, you can see superior colliculus. That is later stage. First, once you have done with basic anatomic structure, then your cisterna magna, all measurements. So try to do with, for one baby, everything, but don't lose the focus. But this is for your understanding and training. This is what I do with, I'm not a master, but I'm evolving. I'm trying to understand and trying to get the concept and think in a different way. So you can report it that way.
Yes, thank you. Do you have any live images or videos while checking the internal cerebral vein, Doppler?
I will try to get one, and I'll show it in the next class. We'll have hands-on at that time, and we'll show it in the next class. Okay, we will get it.
Thank you.
It's not a
Yeah.
big deal.
Yeah, thank you.
Yep.
Sir, the demand for the recording of the classes is growing, sir. We just want to know.
Yes, sir. Sir, recording is there. I'll give it to you. What we thought was, if you give recording, then people won't attend. So that's why we thought we'll keep.
I know,
all
I understand that, sir. The
We'll
only thing is for revision, it will be useful.
Yes, sir. Once everything is done,
Yes.
I'll give it to you, sir.
No problem.
You can give
No
it to
problem.
everyone.
Thank you. Thank you.
Just thought if you put it early, then
Yeah,
people will attend, and live session will always be good for them.
Good. I know. That's true. That's true.
Where can we get the next class and schedule of the?
We are giving it, circulating it everywhere. Even I have put in my NNF Karnataka Facebook page also, and NNF Tamil Nadu also. They are circulating.
We are broadcasting, yes.
And this Friday, we are doing it every Tuesday and every Friday. These classes. So this is a schedule fixed time of 2 to 3. Sir's idea. Kamal sir is doing on behalf of the NNF Tamil Nadu and from ICH. You can follow it up. Is there anything else?
I think if that is Prashant sir for his excellent and lucid presentation of the ultrasound of IVH and periventricular leukomalacia and how to diagnose it and how to predict it. It was excellent, sir. Very eye-opening kind of a lecture, and all those indices. I think it is all going above many people's head before. Now it is more clearer. Ventricular index and all those things. Thank you, sir. Thank you for this excellent lecture. I think there'll be great demand for the recordings also. So yes, and I'm sure our postgraduates would have been benefited by this lecture. And Now they have to do it hands-on and then find out what are the doubts and then clear it. And I think by the time we finish our lectures, we'll be able to provide them with the recording so that they can revise it and then clear their doubts.
Yes.
Now,
Yes.
I think with that, I think we can call it a day today, sir. And
Yes.
I thank the Dinakars. Hello, sir. Hello. Hello, am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Yeah. And also, I'd like to thank Dinakar, sir, for all this organization. I think without his brainwave, I think it would have worked out. Yes, fantastic. I think our class are going really well, and a lot of response to this class, and so much so that I'm getting a lot of inquiries regarding the recordings. And so we are doing well. I think we'll continue. I think these classes are going to extend even till middle of October. And thanks to the Dinakar sir, he had added a lot more topics to this. We had only 8 topics. I think Dinakar sir added 6 more to it. Thank you, sir. Thank you so much, sir. Thank you, Prashant sir. Yes.
Thank you, sir. Thank you, sir. Bye, sir. Bye, sir. Bye. Thank you, sir.
Thank you, sir.
Thank you.